And then the skin will stretch. As you put your retractor, actually the skin will stretch by about 50 to 75% more than what you opened it. And at the end, it's nice to bring it back together. So just get in front of the rib there. First thing I do when I have my opening is I make sure that I'm about the right space. So you want to be about, your thoracotomy to be about one intercostal space cephalad to the apex. If you're right on the apex, you're too low. If you're more than one space on the apex, you're too high. Then I start taking down the beta. Typically on him, I wanted a quick operation. He had a bit of renal failure. I don't want him to be asleep for 5 hours. And so basically I took the beta with the vein. Mostly kind of narrowish pedicle, if you will, and this is kind of what you get at the end. Nice fat beta. And typically when you finish the head is towards your right hand side, you have a little bit of what I call medial attachments that you just take down, and then I like to mark the front of the beta because I'm going to put it away at the apex of the left lung while I do the other grafts, the proximals, and then doing the two distals before I get to it at the end. Typically, as I was saying yesterday, because we're used to it, we do everything off bomb, either non-sternotomy or sternotomy. So the anesthesiologists are very, very good. So at some point, you can come to a stage where you can do the lethal last, because I don't like to stretch as I'm doing the circ. You know, I'm always worried that we're going to damage it. So if I don't have to deal with acute ischemia or left vein or poor LV function, I usually do it at the end. Of course, if there's any instability, I change my plan at that point. So the leta is down, it's now at the left lung, and the next thing is to do, again, quick and dirty operation. Just do a couple of proximals, source this on the ascending aorta. Now I hear objections about this all the time, but we've done it in north of 500 patients. There was one stroke on a patient post-op day 2 who recovered by post-op day 4. And it had nothing to do with the surgery. I think if you do it in patients who don't have peripheral vascular disease and you clamp when the pressure is 75 systolic and you really bring it down to a very low level and you clamp over more than 3 centimeters, that's very important, the length of your clamp. And then when you release, you flush completely as you release the clamp through the graft and through the suture that's not tied completely, you will avoid all strokes. If you were to never be able to clamp the ascending aorta, how are you going to do mitral valve repair? How are you going to do ascending aortic replacement? And everybody's going to have a stroke. There's going to be a way that this can be done safely. I really believe that. And part of it is air evacuation and debris evacuation. Anyway, so you can see here the octave has been put in. It's on top of the RVOT, pulmonary artery. Every patient's a little bit different. And the Nouveau just brings it down, and actually you're able to bring down the aorta towards you. Now at that stage, the blood pressure is like 75 systolic, and I come in with a small DARA clamp, a small C clamp, and just bring this into the field. And the other clamp that comes under is a K Lambert, and that works very well as well. Next, basically just a couple of vein grafts on the ascending aorta. We've tried and true for almost 50 years of bypass surgery, and I felt for this patient this was really perfect. Just using, it's obviously working through a long tunnel, like the camera doesn't make you appreciate that, but it's quite feasible. Here, my fellow is operating. Typically, I'll expose for a fellow and then switch places with him or her so that he or she can do these anastomoses. Then take out the clamp again. Without tying only after the clamp has been come out, making sure that the release is happening through the graft and not through the aorta going to it. And then you have 2 beautiful grafts, which I like to mark because it's hard to really see the entirety of your graft through a small thoracotomy. So you really have to make sure that you have the anterior portion really well established. So now we have 3 distals to do. I typically now only open the pericardium at that point. I open it, tell the residents in front of the LED, imagine you're opening in front of the LED, and all the way down to the diaphragm, and then you need to tee it a little bit so that you're able to lift the heart laterally. So I'm going to start with the circ here, and that OM that you saw in the angiogram, which is a nice vessel. See, it's very well exposed here. I use the Kratos technique, the armless starfish, a little bit of an umbilical tape on a regular starfish, and just pulling it towards you, and in line with the vessel, about 3-4 centimeters from your target site. So a beautiful view of the marginal here. So once you have that, Bob's your uncle, really. Then you bring in the nouveau. Be very, very careful when you do that. Always pinch it. If you lose the tip of the nouveau in the chest, there's only one solution. You need to find a magnet, put it into a sterile pouch, and then bring the magnet into the back of the left row field. That's the only way you can search for it for half an hour. Trust me, I've done it. You will not find it. The only thing that will find it is a magnet. Just a little tip in passing.
I have a long silk suture. I have a long silk suture on that.
So I find it gets in the way. I don't like to do that. I don't put anything through it. Now I've learned my lesson. I don't drop it anymore. Anyway, so you can see basically just a normal vein graft, beautiful exposure there to do that. So that's kind of 1-2 type of territory. Don't forget, always tell the nurses, if there's one thing I care about you counting, is the silastic occluders. I want to make sure, because I came close to forgetting about it once or twice in my career. It never happened, but can you imagine if you were to have an angiogram here? This is what really it is. So yes, you are. Right?
No consultation.
Yeah, the flow is good though.
So, all right.
How do you mention the grafts on the aorta?
Yeah, so I didn't show that, but typically I stretch it. I put it under tension and I add a couple of centimeters. So that's enough. I've left so many of them too long over time because I'm always afraid of one too short. But they can be a problem with a graft that's too long, right? I've probably lost a couple of grafts over the years because I left them too long and they fold and they're just too much tissue. So now we're doing the diagonal. You can see the marginal behind, and that diagonal actually was a bad vessel. You can see she's all yellow. And if I knew, those of you who said don't grab the diagonal were probably right. It was apologies for the expression, it was a shitty vessel. So we did it, we had to roll through it, but it was not perfect. If I had known, I would not have opened it. Anyways, it's there, it's done, we have to roll through it.
I love your exposure, it's gorgeous. It's really like the concept here, and I think off pump, you guys, off pump on pump, like if you know how to expose, now in minimal invasive is another step, but if you are in a sternotomy and you have never done an off pump, start to understand how to manipulate the art of pump, slowly, careful, minimal movement, and you see how nice when you have stabilized. Look what.
And then the last anastomosis, I always tell the team, it's dessert. It's the lethality. It's like you finished your meal and now you're having your key lime pie. So put that on. You can see it there. It's mostly seen. To Gianluca's point, I think it's there. You can see it under the epicardium. There's a little bit of fat on it, so you were right, Gianluca. I'm scratching that now, exposing it, and we're gonna open it. Should be good. And just putting the lethality onto it. Tying at the end. I'll show you the final result. Basically, the three grafts here. You can see the marginal, the back, you can see the diagonal, and then I'm going to show you the lethality. So 3 grafts on the left, quick and dirty. I think it works well. We have a new game now that we're doing. We're trying to get the patients out without any. The nurse practitioner who I work for, she's very, very strict. If I bring a patient with a bad outcome, I fear she's going to fire me. So we're trying to mitigate anemia as much as we can. And then that patient went down to 132, and he went home on post-op day 2. So obviously a lot went into this anesthesia. I cannot underestimate the role of each team member on this. So open it for discussion. Any questions? Would you have done something different? And this is my last slide.
Would you have done a Y graft? Sorry to go, please take the. Go take it.
Please go ahead, yeah.
Would you have done a Y graft or Y graft?
When we started mixed cabbage back in 2005, we were doing Y grafts. We couldn't do grafts on the ascending aorta. And we were doing reverse Ys, and there was radial, then going to the TEA, and what I would call reverse anastomosis, because we're actually coming to the left. I think it works well. Whatever you like. I like independent grafts. I find they're nicer. Ideally, this is just kind of a basic operation, but we do a lot of multi-arterial, lita, and then source through a Y graft. I think if you're complete arterial, it makes a lot of sense. But sometimes it's nice to also have like the classic CABG times 3 times 4 operation with ascending aortic stenosis.
Islam Sharif from Uzbekistan. Thank you very much for fantastic presentation. The only thing I would get also PDA, graft to the PDA, and because in some view there was like critical stenosis, maybe there is eccentric plaque. And just we forgot about the different technique of gain harvesting. We now would take it pedicle, no touch, no touch technique. There is very nice work from some Scandinavian group showing fantastic long-term results. So if you cannot use artery, at least if you have to use vein should be no touch.
Yeah.
And just if you allow me a couple of technical questions, do you encircle aorta to bring it?
No, I don't. I find that very scary, and Joe Medin does that. But when we start the proximal anastomosis, I find it's not necessary. We have a technical paper about this. There's like 12 steps to expose the aorta, but it works every single time, and you're able to get it into view. And at the end, if you're really stuck, I always say, if you've done all the steps and you still cannot see the ascending aorta, you still have two options. You can go up one intercostal space, or you can put the patient on pump, and these two things will solve it every time.
And which intercostal is your intercostal of choice? For example, if you need to do also proximals on the aorta.
You enter a fourth?
Yeah, typically fourth or fifth, yeah. If it's all on the left, it'll usually be on the fourth. If you need to do PDA, you're not going to be able to do it from the fourth. You really have to be in the fifth intercostal space, yeah.
And just one more question, if you allow this, how from where you put this stabilizer from distals, and if you would do PDA, from where you also put the
yeah, so the stabilizer is always 2 or 3 intercostal spaces below. I put the skin incision pretty far, and then I tunnel it a little bit for at least 1 space under the skin, and then I enter into the chest. So the reason why I don't enter right away is I don't want to enter and then kind of wrench up the rib and cause more pain to the patient. And it's always in the axis of the incision, if you will. If the incision's here, it'll be kind of in line towards the neck. It's not on the side or at the front. And when you do a PDA, typically you'll have to, the pod is going to be a full 90 degrees, sometimes even more than 90 degrees from the rod. And that's how you have to do it. Typically I would put the starfish, the positioner, on the acute angle of the heart, pull towards the left shoulder, and then that gives you about 50% of their exposure, and then put the pod of the nuvo on there and expose the PDA. It actually works quite well. The PDA, initially scary, but it's like in open LCAP, it becomes one of the easier vessels, to be honest.
Thank you very much.
And actually, you could see on one of the images, you could see the PDA. I'm not going to run it again unless you're pretty interested, but I showed it to you towards the end.
Frank Chuli from Bristol. The way we identify the apex of an ultrasound, we usually go 1 intercostal space up, but that doesn't always allow us to see the aorta. So do you have a strategy for how you manage the pericardium in that position? Because if you go too far up, then you can't get enough length on the mammary.
That's right. That's a great question. And initially, my peers, I used to do that. I used to, first you have to be on both lungs to identify the apex. It's very difficult to do it. The ultrasound is not going to work when the lung is down. So you have to kind of reinflate the left lung. And you can kind of make the quote-unquote demonstration that, yeah, this is the space we're going to take because the apex is one lower. I don't do that anymore. But that being said, there's no crime in being in the wrong intercostal space. Like, this is one of the key things in mixed cabbage. I think all of us here are doing it. Really, if you're in the wrong space, you're never going to be 2 spaces away. It's very rare. You're going to be 1 space away, either too high or too low. And sometimes, use 2 spaces. It makes the operation really, really easy. The only thing I would say, when you use 2 spaces, be careful of the rib in the middle. It becomes extremely weakened, and it will break very easily. Once you have a rib that's open on both sides, It's not the end of the world if it breaks, but your patient is still going to recover quickly. I think it's way better than a sternotomy. You know, they're jumping around after a few days. But that being said, one thing I found that helps is then to use a soft tissue retractor. I didn't have it on this case, I usually don't use it, but if I go in two spaces to solidify the rib and not have this direct pressure on it from the retractor, I use a soft tissue retractor, and I find I have less ribs breakage by doing that.
Question and a comment. You mentioned about the length of the leads during this. I mean, I usually get more concerned when I'm doing open sternotomy, but with this, I try to keep it as long as it is. Is it really, when you actually ask IC to inflate the lung and it lies okay, has anybody has issues with having a longer lita to the LAD because of that length, or is it an optimal length when you do that? Because sometimes I'm worried that I'm going to cut it short, and then after the lung up, it's like you might be under tension.
Yeah. Typically, I don't think it's a big problem if it's if the lita is a little long. Typically, with mixed CABG, when you build it, you'll gain a lot of length after you've done doing it, right? There's a few factors for that, like the way you retract. Also, the one lung ventilation really shifts the LAD a little bit towards the left. When you go back on two lungs, which I would recommend, really do it on the direct vision every single time on every mixed CABG. Go back on two lungs and take a look at where your grafts are so that you don't have a kink. When I started back in 2005, we had one case which I had to reopen. I did sternotomy on a patient because it was a kink, and I didn't understand what the kink was. I do this sternotomy and I'm shaking it out. I'm so afraid, something's wrong. And then I find it was a 5-minute thing. It was basically the lung had basically taken a fold of the lead and caused the kink. So just to outline the importance of watching and observing before you close everything the way it lies on two lungs. And to your point, generally the anastomosis is going to come closer, so you're going to get a bit more lax than when you were building it.
Then the other thing, which is something I had observed, and I just ask your opinion about it, about the quality of lead harvest between the robot and MI with minimally invasive. I do about 200 bypasses a year. Half is almost sternotomy and half robotic mid-caps. And almost always the robotic harvest, the lima flow is amazing. I never had to do any pattern or anything. When I do my open sternotomy and taking the limb down and then do both skeletonized, I feel sometimes the flow is little and you have to get some pattern, you get a better flow. And I always think that the robot has, when you do it with the robot, it's a much less traumatic and less traction than with minimally invasive and with open. Is that something you noticed?
No, I think your point's well taken. I think you get a great memory with either, but the robot is definitely less stretching. Right? And that being said, the robot, in my hands, takes a little longer. But it's a different mindset, right? The patient's asleep. There's no bleeding by definition with the robot. There's nothing, right? If you're bleeding, you're done. You have to convert. Right? There's micro dissection, very minimal third spacing, no stretching. When you're doing this, what I call conventional mix, you really have to use the roll track and the thoratrack and pull up. And to patients out of pain, I don't know. You need a trial to really figure it out. But I'm sure that there must be some degree of tissue stretching. So your point's well taken.
Do you think this will have a long-term effect on the patency?
I don't know. I hope not. I think either way, to take it like that. I mean, you can take a right memory from a small thoracotomy, but in my opinion, it's not as long as when the other beauty of the robot is you get the full length, especially on the right side of the conduit. If you do it through thoracotomy, are you really going to have all the way from the right subclavian vein down to the bifurcation, completely freed up, skeletonized, beautiful like a robot? I doubt it. Maybe some can do it, but I think that's not for the average mortal.
But what can also contribute to this effect is the CO2 insufflation. The CO2 is known for vasodilatation. When you harvest 45 minutes robotically with CO2 in contact with the memory artery, that's different from direct vision. Because with open, because I found see it 3 times magnified, 2.5. It has flow. All the studies we published, Archwell, everything, the syntax is with open harvest memory. So maybe the difference is that we see in practice the details we see, they're great and it makes it safe, but maybe for long term it does not affect maybe after all.
Actually, I can tell you, I investigate a lot, and then Dario, you give you the microphone. I investigate almost 90+% of all my robo. I love it. I like to give an angel after. I want to make sure it's good with the rima, ita. So, you know, you learn a lot when you see your own geography, when you see your own anastomosis, and like the patency of all of these anastomosis are really, really nice. So I think, as everything we do in surgery, we have to be precise, calm, slowly, but you can do it robotically, thoracotomy. Just technically it's more demanding, but just need to be done. You can do it properly. Dario?
Very short question, because would you consider in this patient also a sequential venous graft configuration, so venous to the diagonal and then the MO? So we have also some data showing that sequential graft even is better for the patency. You have that target the diagonal. Is it just preference or is it technically more demanding with this approach?
Yeah, no, I'm sure you could do sequential as well. It's, to me, I find it a bit more complicated. You know, if you saw how they were lying, like the marginal was fairly far compared to the diagonal. I didn't think it was that feasible, but I'm sure some of you will be able to pull it.
Hi, Mark.
Please.
Mark, I just want to ask, you have used a side batter, but initially you taught us using a signet clamp. So why you are not using a signet clamp now for the proximal anastomosis?
What's that?
I think he asked a signet clamp for
for
proximal anastomosis.
proximal.
Why you didn't use signet clamp? It was a signet clamp.
Yeah, no, it was just a regular K-Lamber.
Oh,
Yeah, it was a regular.
Run-of-the-mill type of yeah.
So you do not promote a signet clamp for the proximal?
Yeah, I don't really use a signet clamp. There's the K-Lambert is an old vascular clamp, right? If you use a regular Cobra, it's not deep enough. It's too long and it's not deep enough. The K-Lambert is a little less bulkier and deeper. It works really well for mixed cabbage. Now you need a shaft that's long enough. Sometimes it's not sufficiently long and you need a longer kind of the handles of it. But I find that works well. But the signet clamp will be fine too. I've been looking around for maybe if industry is here for a flexible kind of Cosgrove type of K-Lambert, that would have a flexible shaft. I haven't found one yet, but I'm sure there must be one out there.
I'm sure. I love signet. It's a great.
Okay.
Guys, 10 minutes.
We move on to the